Good afternoon, everyone. My name is Lori Brady, and I'm the Vice President for Community Integration, Partnerships, and Ambulatory Care at Sunnybrook Health Sciences Center. It's my sincere pleasure to welcome you to our April Speaker Series event on understanding personalized cancer care. April is Cancer Awareness Month in Canada, a good time to think about the lives touched by this disease, as well as new advances in cancer care. Before we begin, I'd like to take this opportunity to say that at Sunnybrook, our mission is to care for patients and their families when it matters most. It's part of what makes this place special. Sunnybrook also cares about our collective responsibility to achieve reconciliation with Indigenous peoples who have lived on this land for generations upon generations. We acknowledge that our campuses are located on the treaty territory of the Mississaugas of the Credit First Nation and ancestral and traditional lands of the Anishinaabe, the Haudenosaunee, the Ojibwe, Chippewa, and Huron-Wendat nations. Today, this land is home to many First Nations, Inuit, Métis, and urban Indigenous people from across Turtle Island. We value their contributions, past and present, and we are grateful to work in the community on this territory. So back to this month's important topic. According to the Canadian Cancer Society, nearly half of people living in Canada will be diagnosed with cancer in their lifetime. In Canada, there are currently 1.5 million people living with or beyond the disease. And I'm sure we can all think of someone in our lives who has been affected. The good news is that the survival rate for cancer has increased considerably over the years, thanks to advances in research, prevention, diagnosis, and treatment. Sunnybrook's Odette Cancer Centre is the second largest cancer centre in Canada, and it is helping to lead the way in innovative care designed to meet the unique needs of each patient. Behind the center's reputation for highly specialized, comprehensive cancer care is a commitment to optimal, evidence-based, and tailored treatment plans. Today, you'll hear from key members of the Odette Cancer Center teams who will help us gain a better understanding of personalized cancer care. And alongside our esteemed panel of presenters, we're very fortunate to have Dr. Calvin Law moderating this event. Dr. Law is the chief of the Odette Cancer Center and the regional vice president of Cancer Care Ontario. He also holds the full rank of professor in the Department of Surgery, as well as the Department of Health Policy, Management, and Evaluation at the University of Toronto. He is a cancer surgeon and an affiliate scientist at the Sunnybrook Research Institute. This is just a snapshot of his biography, but as you can see, we're in very good hands having him moderate today's event. Calvin, thank you so much for being here. How about I pass it on now to you and you can moderate us through.
Thanks so much, Lori, for that introduction. I thank you. The team is what makes our program special, and I'm so happy to have them spend some time with our community today. And first, I'd like to say hello to our general community who are joining us today online to learn a little bit more about personalized cancer care. That's a commonly used word, so we wanted to say, what does that actually really mean? And that's what today is all about. We want you to hear about how we're moving away from a one-size-fit approach to cancer care and to look more at you and your unique features and trying to understand how we could use that to your advantage in planning your treatment. As you're going to hear shortly, Sunnybrook's Odette Cancer Center has leading expertise for people caring for patients with cancer and driving our future towards this personalized cancer care, because at the end of the day, it is you who we are serving, and the care we give you needs to be better every day. Today, we are so fortunate to have a great lineup of speakers. I can't wait to introduce each of them to you, but just very briefly, first, Tracy Graham, who manages our genetics team, will provide an overview of how your genes can play a role in cancer care, including surgical and drug treatment plans. Next, Dr. Eileen Rakovich, who is our program research director, will expand on unique aspects of cancer which allows for this type of personalized treatment and to look ahead to where that future is going to take us in terms of a brave new world called precision oncology. And finally, Dr. Deepak Dinakaran, who is one of our outstanding leading radiation oncologists, is going to also show us how radiation, it's not just a beam, but something that can be personalized to you and how that can impact your outcomes. So as you can tell, we're going to have a great session with you. I think it's going to be a wonderful day, and there's so much to discuss. And we'll try to set some time aside at the end to answer any questions that you might have or you might come up with as you go. And for everyone who submitted a question online earlier, know that we have them. And for those of you who come up with questions while we talk, please use the online portal to submit your questions, and we'll try to get them answered at the end of all of the speakers. So in case we don't get to everyone, we'll forgive you ahead of time, but thank you again for joining us, and we'd like to get started. So let me first start by introducing our first speaker, who is Tracy Graham. Tracy Graham is a longtime genetic counselor who has helped so many of our patients over the years, but she's also one of our leaders and manages our Cancer Center's genetics program. She's been here for more than 20 years, and it's amazing because you wouldn't know it when you meet her. She has so much energy and a smile that will make everyone feel at home when she talks to you. She's consulted people with strong family histories of cancer, so you can imagine how much concern that they may have, and is able to take them through a risk assessment, arrange genetic testing, and basically walks you through the whole exploration of understanding how your genes impact you. We cannot be happier to have somebody like Tracy on our team. So Tracy, thank you for joining our panel today and sharing your wealth of expertise and also incredible length of experience so that we can share it with our community. And now, if I can, hand it over to you.
Thanks so much, Dr. Law. I really appreciate the nice intro and for inviting me here today. I'm very happy to present to the group based on my role as a genetic counselor and my time here at Odette. So I'm going to jump right into it, and as indicated, I'm going to be talking about how your genes can play a role in cancer care. And so, hang on here, let's advance the slide. There we go. So just a brief overview. I'm going to touch on a little bit about genes and mutations and really the types of genetic mutations we see, and a little bit about the types of results, both in tumor and in our bloodline. And really at the end of the day, how is genetic testing going to be helpful? So I want to just start by saying, what is a genetic counselor? Some of you may know very well what a genetic counselor is, and others may have never heard of us before. And so we're a unique group of allied health professions that work often in multidisciplinary healthcare teams. And really, we are there to provide individuals and their family members with information on the nature, inheritance, and implications of different genetic conditions. And so we all have advanced training, a master's in science, specialized in medical genetics and genetic counseling. And you're going to find genetic counselors across a broad spectrum of disease sites, from metabolics and pediatrics, prenatal genetics. And of course, here at the Sunnybrook Odette Cancer Center, our genetic counseling team is focused on oncology or cancer genetics. And so no genetic counseling talk is ever going to be complete without showing at least one pedigree. And so here's my pedigree, which is a family tree. And it's really probably the best tool that we have as genetic counselors to show a snapshot of someone's entire family tree all in one spot. And so you're going to see on this pedigree, the women are denoted as circles and the men are squares. We join the brothers and sisters across the line, and then up goes the parents, and up another generation is the grandparents, etc. And so you can see all the shaded in relatives have had a cancer diagnosis. And for me as a genetic counselor, this is really a good way to assess immediately the likelihood that I'm going to see a hereditary cancer in this family, or the likelihood that there may not be hereditary cancer, that it might be a low risk looking family tree. And so some of the key features that we look for are going to be multiple cases of the same kinds of cancers, several generations affected, sometimes early age of onset, different kinds of cancers that combine. So in this example, we're going to see breast cancer at a young age, but also an aunt with an ovarian cancer and an uncle with male breast cancer, which on its own is a pretty rare disease, but in combination with these other cancers can make it actually looking like a strong hereditary family. And so now, what is a gene? So in our body, we're made up of thousands and thousands of cells, and in every cell of our body is our genetic material made up of genes. And genes are really the basic unit of heredity. And we get all of our genes from our parents. Half come from our mother and half come from our father. So our genes come in pairs. We have 2 copies of each gene. And really the genes are a region of the DNA, which is a sequence of base pairs, a code, which is really the instructions for how that gene should work. And so when there's a change or an alteration on that DNA sequence, we call that a mutation. And so we're all born with mutations. Every one of us has a handful of mutations, and many of us may go our whole life and not know what those mutations are. In our world of genetic counseling, what we're often doing is doing genetic testing to try to identify if people do have some of those mutations. And so we know that hereditary cancer is actually the smallest part of this whole pie. 5 to 10% of all cancers are truly hereditary, which means they are inherited from a parent. They're being passed down from one generation to the next. We will also see about 10 to 20% that we call familial, where there's a cluster of certain cancers in a family, but it may not be necessarily hereditary. There could be some common genetic factors, but also maybe some shared environmental or lifestyle factors that can be playing a role. And then 70 to 80% is sporadic, which means it is happening by chance, often at older ages of onset, and has no implication from being passed down. So let's talk a little more about the types of mutations we see. And I always like to start by saying that all cancer is genetic, okay? But again, only 5 to 10% is hereditary. There has to be genetic mutations occurring within the cells of our body for cancer to occur. But there is a difference between a germline mutation and a somatic mutation. And so germline is where, historically, as a genetic counselor, that's my world. I'm looking at those mutations that people are born with. They are present in every cell of your body, including your germ cells, meaning the egg cells and the sperm, and those can therefore be passed on to the next generation. And those are different compared to the somatic mutations, which are mutations that we are not born with. They are actually acquired throughout your lifetime, and then therefore they're present only in the cancer cells of that tumor itself. And that's a really important distinction as we move on, because there's a lot of testing happening in both the tumor and in the germline, both of which can have implications on your cancer care. So just to briefly touch a little bit more on this somatic testing, because I think it is really important, it's becoming relevant for a lot of patients in their care. Again, this is testing for these acquired mutations within the tumor cells. So these are not ones that you're born with. Somatic testing is becoming more widely available both in a clinical and research setting, and it may potentially impact on treatment decisions, and is often being primarily ordered by your physicians or your oncology cancer team. These are just some examples, and there are tons of examples that I can give of testing that's happening within the tumor itself. But a few common ones that overlap both with us in genetics, but are seen commonly, could include the hormone receptors that we test for in breast cancer. So for example, the estrogen receptor, progesterone receptor, and the HER2/neu. And we know depending on the different status of these markers, that could have an impact on someone's treatment, whether they may receive chemo or not, whether they may receive a hormone treatment or not, will have an impact based on those receptors. And we can see KRAS mutations in cancers such as lung, colorectal, pancreatic, and others. And we may see BRAF mutations in melanoma cancers. And then one that's really common right now that overlaps directly with the genetic counseling team is these BRCA mutations that we can see sometimes in certain types of ovarian cancer tumors, in particular a high-grade serous ovarian cancer. Many times these tumors will be sent off for sequencing of the BRCA1 and 2 genes within that tumor tissue itself to see if there is a somatic mutation in that, which might change the different types of treatments that they have. And then finally, we can see these, what we call NGS sequencing panels, which is just next generation sequencing, where we're testing for multiple genes in the tumor setting to see if there could be some acquired mutation that might change, again, a clinical trial that a patient might be eligible for, or a different drug. And how does that compare then to germline genetic testing? So again, germline is testing for these inherited mutations that are present in every cell of the body. These are offered based on provincial Ministry of Health standardized genetic testing criteria. They are going to be ordered by either genetic counselors or in some situations directly by an oncology team member. And our genetic counseling platform has really switched since the time of COVID, where we are now on a virtual platform for all of our genetic counseling sessions. And also patients have the option now of getting their blood drawn, not only just coming to the Sunnybrook Odette Center, but we can also facilitate through local life labs and Dynacare. And so this has really opened up access for genetic counseling, not just in Toronto, but in the province. And most genetic testing is going to be done through a simple blood test and in certain situations, saliva. And so for genetic testing, you're going to either get a positive result, which means we found at least one or more mutations. A negative result is no mutations identified. And of course, in genetics, we're never black and white. There is a gray zone for sure, where we're going to see these uncertain results. And we call these variants of uncertain significance, or VUSs. So this is a busy slide, and it's not to make you read through all these different genes listed, but it's really just to show you where we've come in genetic testing in the last several years. The highlighted boxes in red represent sort of historic testing that we've been doing for over 20 years. Started as research testing for both BRCA1 and 2 for our hereditary breast ovarian families. And the 5 listed below are the Lynch syndrome genes that we've been testing for Lynch syndrome or hereditary colon uterine cancer families. And now we've expanded to panels of genes. And so we have panels for many, many different cancers: gastric, melanoma, pancreatic, kidney, just to name a few. And most of our panels are going to take about 2 to 3 months to get a result back. And we do have the option of expediting for a 3 to 4 week turnaround when it may have an impact on medical management. And so just to touch, I guess, on a little bit about the genetic test results themselves, because I think I get a lot of patients asking about how to interpret their test report. And I think it's important. So we do have a spectrum of results from, on the left, pathogenic and likely pathogenic. In the middle is those VUSs. And on the right is likely benign or benign. And the pathogenic, likely pathogenic, is really representing those positive results. Those are the true mutations that we're finding. Whereas on the other end, the benign and likely benign are negative, and you won't even see them showing up in the report. They're just reported as negative and not relevant. And then those variants of uncertain significance will get reported. So they, along with the true mutations, are going to show up on our germline genetic reports. And to compare that on somatic results, because they are a little bit different in why they're being done and how they're being reported. So we don't report a tumor result the same way. You're going to often see it as actionable or non-actionable. And that, again, is because it's being driven predominantly for treatment purposes, because it's unique just to those cancer cells. Or we might see it as a tier 1, tier 2 for being a positive result, and a tier 3 for those sort of uncertain variants. And so that's just a distinction between a somatic and a germline report. And so at the end of the day, how is this all helpful? There's a lot on this slide, and I want to touch first on the first 2 and the last 2 items, because again, as a genetic counselor, I kind of look at the big picture. Often it's a closure. It gives patients some information possibly as to why they've been diagnosed with what they've been diagnosed with. In particular, when they're really young, we might see a colorectal cancer at age 28, and that's really a young age. Finding out that there's a genetic diagnosis behind it sometimes gives them that backup and that explanation as to why it happened, and that it was in their genes. It wasn't something that they did or didn't do. It was something they were born with that put them at a much higher risk of getting that cancer. It also can impact surveillance. We know that with many of these genetic conditions, there's not just one cancer site that you're at risk for. And so there could be future screening, future early detection that might be important for putting onto the radar. And then, of course, in genetics, we look at the family picture as well. So just to touch briefly, there could be implications for family in both genetic testing and also in the preconception or prenatal testing world. Once we identify a mutation in some of these cancer genes, we do know that if one partner, decides to do family planning with another partner who both happen to be carriers of the same type of mutation, then there's a risk of having a child born with 2 copies of this mutation, which has its own set of implications for family planning issues. But really what's important for today is this middle section, targeted therapies and guiding radiation or surgical planning. So we know that genetics has come a long way as far as having an impact now on actual treatment for cancer care. This has become something really relevant, and we've really overlapped into the oncology world. Targeted therapies are really becoming prevalent. In particular, we do see PARP inhibitors, often related to BRCA1 and BRCA2 related cancers, including certain breast, ovarian, prostate, and pancreatic cancers. This is also moving into other genes. We're starting to see some trials being done for PARP inhibitors related to ATM mutations in prostate cancer, even PALB2 mutations. So there's a lot coming on the horizon. It's a very exciting time for some of these drug treatments. Then we also see immunotherapy being relevant with some of our Lynch syndrome related cancers, including colorectal cancer. And so this is where genetic testing can be so important to know early on in the process, because it might change the type of chemotherapy your oncologist might give you. And it might also allow you options for additional drug treatments, either at the time of your diagnosis or perhaps down the road, as a plan to know for maintenance therapy, or at a stage, if someone were to progress on their cancer, this now becomes an additional option. So it's become really relevant. And then with guiding radiation and surgical planning, there's a lot of genetic testing that we try to do on a more expedited, urgent basis, because it might actually change how we would plan out the surgery. For example, some of our hereditary breast ovarian families, the woman might be deciding to have a lumpectomy, but should she identify herself as being a BRCA carrier, she may choose for a little more of an aggressive surgery, like a bilateral mastectomy, as a way of treating that cancer, but also prevention for the other breast cancer. And it might change colorectal surgery or resection for a Lynch syndrome carrier. So these are important things that factor in to current status. And in certain situations, again, women may decide instead of a lumpectomy and radiation treatment, they may go for a mastectomy and forego the radiation treatment. Not always possible. Certain cases may need radiation regardless. But again, these are conversations that we can have with you at the time to sort of have that impact. And so then just to kind of close, I'm showing an example of one of many posters that we've developed that we have throughout the Odette Cancer Program. This one is one of our breast cancer ones, and it's just a way of showing and highlighting a lot of the different criteria that have changed to now ensure people are eligible for genetic testing. And there's going to be many families that may have had historic genetic testing 5, 10, 20 years ago that may be eligible for updated testing. And so I certainly encourage people to speak with their physicians if they feel that genetics might be something that they're eligible for. And I've just highlighted the QR code. If anyone is interested, you might be able to scan it. And it just provides a direct link to our website and a genetic counseling video that we've developed to give a little bit of background information. And of course, you can always go to our website to get more information, including our referral form. We do have a genetics email, occ.genetics@sunnybrook.ca. Anyone is welcome to reach out if you have questions. We are happy to help facilitate and navigate you. And with that, I'm going to end here and happy to later answer any questions people may have. Thank you again.
Thanks, Tracy. That's amazing. For me personally, as a son of a mother with colon cancer and a son of a father with prostate cancer, every time you talk, it means a lot to me. And it's amazing how things have really progressed over time. So thank you. I'd like to now introduce our next presenter. Yeah. Welcome, Dr. Eileen Rakovich, one of Canada's outstanding cancer doctors. She's also, fortunately, a radiation oncologist with us, and she has an active clinical practice and research program based on breast cancer. She is our program research director. So she's the boss of all of our research. And as such, she is truly at the forefront of Sunnybrook's effort to advance personalized and precision oncology. Dr. Rakovich also serves as the L.C. Campbell Chair in Breast Cancer Research at Sunnybrook, and she's a scientist with the Sunnybrook Research Institute. At the university level, she's a full professor and vice chair of clinical affairs in the Department of Radiation Oncology and an adjunct senior scientist at the Institute for Clinical Evaluative Sciences. We are so glad that Dr. Rakovich is also here and has some time for us to share her expansive expertise. And so without further ado, Dr. Ragovich, let me pass the microphone to you.
Thank you. Thank you, Dr. Law. Very kind words. Okay, let me just start here. Okay. So thank you for inviting me to speak, or giving me an opportunity to speak to our community and on the future of cancer care. So no small topic, but I've tried to just make a very brief summary to give some insight into where we are currently in the treatment of cancer and where we're going in the future. There we go. So today, how are individuals diagnosed with cancer? It might be through a screening test such as mammography or a colonoscopy or a PSA, or it might be through the presence of symptoms, a lump or bleeding, etc. So diagnosis of cancer is made. A biopsy is taken, and you can see here, these are cancer cells seen under the microscope, what we refer to as H&E staining, to make the diagnosis of cancer. And at that point, you may be referred to our cancer center to see our multidisciplinary expert team for treatment recommendations. When you come to the cancer center, the first thing we do routinely is do a series of tests to see if the cancer has spread, what we refer to as the stage, CT scans or bone scans or other tests. And once that's determined, we can determine together as a team of what the optimal treatment will be. So for a group of individuals with a similar type of breast cancer or pancreatic cancer or lung cancer, a treatment recommendation will be put forward. And that might include surgery, radiation treatment, and drug treatment. Now, for a group of individuals who apparently have a very similar type of cancer, similar stage of disease, are given a recommended treatment. And for some individuals, they're cured. The cancer never returns and you live out your natural life. However, for other individuals who apparently have the same kind and same stage of cancer, the treatments are not as effective and the cancer can return or spread to other organs. And so how do we improve the cure of cancer? How do we better determine, this is where a lot of the focus of research is now, who really needs treatment, by better understanding which cancers are very indolent and will never spread or come back, and which ones will spread and come back, which are more aggressive, where treatment is really needed. And how do we match the best treatment for each individual? As I just said a moment ago, right now, the best of our ability, we treat groups of individuals who apparently have the same type of cancer. And how do we get to a more personalized approach? Well, we are able to now sequence the entire human genome. And with the ability to measure the genes within specific cells, be it a cancer cell or a normal cell, we can determine which genes are turned on or turned off. And that's referred to as the molecular profile of the cancer. This allows us to see changes within the cancer that are not actually visible to the human eye. And I'm going to give you an example of how that helps us move towards personalizing cancer treatment. Okay, here's a basket of fruit, or may look like eggs in this schematic. But the point is, from the best that we can see with the best technology, they all look the same. However, with the ability to do molecular profiling and imaging, we can see differences now that we weren't able to see just a few years ago. So we can actually see with molecular profiling that some are yellow, maybe lemons, others are red, maybe they're apples or limes or orange, and we can now see differences that we weren't able to see just a few years ago. So here's an example of what a cancer will look like under the microscope. And it all looks very similar. The purple, dark stained are the cancer cells. The pink stain is the surrounding normal tissue, very similar. But we now have the technology to measure and now visualize genes within the cancer cells that are turned on, and genes that encode proteins. We can visualize the proteins as well. That is called spatial profiling. And with the support of our philanthropic community, we've been able to acquire the equipment to now do this. And here's an example of what profiling, molecular profiling of this, where you can't see different, they all look similar. And here you can see different proteins and measure which genes are turned on and off, how many cells are they turned on and off, which proteins are turned on and off in the cancer, in the surrounding normal tissue. This provides an opportunity to analyze and detect differences for every individual cancer that we were not able to do before. The vast amount of information that we're able to acquire, and that with artificial intelligence and our ability, we can analyze all this data together and start to see differences among individuals' cancers that we weren't able to detect before. So how does that move us forward towards personalizing cancer treatment? Well, again, going back to the schematic, if you see on the left, individuals with cancer all look similar and to date would be treated in a similar way. But with molecular profiling, we now can see, well, this individual with lung cancer has a different molecular profile from the other one, or breast or prostate, irrespective. This is happening across all cancers, where you now start to see differences and group patients differently according to the molecular profile. And once you do that, you can match the best drug treatment or radiation treatment, which you'll hear more about from Dr. Dinakaran, but you can now match and individualize the best treatment for that specific individual with cancer, personalized or individualized cancer treatment. And this is going to enable us to direct better treatments, more effective treatments, and help those avoid the side effects of treatments that are not going to ultimately be effective. That's the future of cancer treatment. So at Sunnybrook, we are very fortunate to be a very large research and have a large research program with many scientists working on this technology and working to improve this technology. We have digital pathology. We have the ability now to do genomic profiling, both to measure genes and proteins. And we have the bioinformatic capability to start putting all this information together. We're a very large program. We have a lot of patients that we can see to start to refine the treatments and personalized cancer therapy. And we are very dedicated to clinical trials that aim at matching the right treatment to the right individual, personalized cancer therapy. And that is true across all the disciplines, across all the treatments. So surgery, the focus of precision oncology and surgery lie in part in robotics. And I'm not going to speak more to that, but just to let you know that we're really working towards improving and personalizing treatment, surgical treatment, radiation treatment, as well as medical treatment. And so there's a whole very exciting field of precision surgery with augmented reality and robotic surgery to make surgical excisions easier for the surgeon to do with less effect on the normal tissue. Precision adaptive radiation therapy, you'll hear a little bit more about from Dr. Dinakaran, and this is a huge evolving field in improving radiation treatment and the ablative treatment of cancer. And then the third domain is in medicine. Chemotherapy, the ability to do this molecular profiling and identify genes has led to an explosion of discovery of new drugs that target genes that are turned on or off. We call that targeted therapy. But in addition to that, what we really want for the future is to be able to predict in advance what is the best drug or drug combination for each individual before we administer it to the patient, because these drugs all have side effects. And so one way that we are looking to do that is by taking a sample of cancer cells, as you see here, depicted here, and we can grow them in the laboratory. And when you grow them, they form spheres, as you see depicted here, and that's called an organoid. And so Dr. David Andrews and his lab is able to do this now, where we can take cancer cells, grow them in the laboratory, and then expose for each individual patient that has this, expose the cancer cells to a whole host of drugs. And then with that, we can test in the lab which drugs are most effective against that cancer. This is still research. This is not being done yet clinically, except under specific research circumstances, but it is a very exciting path to follow forward for the future, where a sample of cancer is taken, grown in the laboratory, exposed to a panel of drugs, can be hundreds, and then provide in a rapid period of time the clinician with the information on what is the most effective drug treatment to guide treatment decision-making. So this is something of the future, and we are working and developing it now. We are able to grow organoids. We have trials up, and we're going to focus very hard on expanding that to individualize cancer treatment. So that the future of cancer can be very similar. I use this analogy because it seems to fit, that if one has a urinary tract infection or symptoms of that, we don't treat everyone with antibiotics with a trial and error. We take a sample of the urine, we grow the bacteria in the lab, we expose the bacteria to a whole host of antibiotics, and in a very rapid period of time, we give the clinician, the doctor, a list of what bacteria it is and which antibiotics is it most sensitive to, and that guides treatment. And this is really quite analogous to where we see the future of drug treatment and perhaps even radiation treatment going. So thank you for the opportunity to speak today. I welcome any questions. And Calvin, I pass it back to you.
Eileen, thank you so much. It's amazing the work that you're leading for all of us to decode the mystery that cancer really is. So that's incredibly exciting. Just for our audience and our community out there, just a quick reminder that your questions can be received online, and please submit them through the Speaker Series website. Now, I have the pleasure of introducing our final speaker for today's amazing event. And this is Dr. Deepak Dinakaran, who really represents the mission that we put on one of our logos, which is inventing the future of healthcare. Because Deepak is going to change the way we give radiation. He is leading our efforts and our science in improving that treatment every day. He's a scientist with the Sunnybrook Research Institute. He's an assistant professor in the Department of Radiation Oncology at the University of Toronto. And we are so pleased that he's given us some of his time to show us a bit of the future today. And with that, Dr. Dinakaran, over to you.
Thank you so much for that introduction, Dr. Law. Very gracious of you. I'm just going to pull up my screen here. Okay, there we go. So it was great that we had our speakers explaining about what targeted therapy is in precision medicine and Go First. My goal is to give you some real world examples, both current and coming up in the future, of how we apply this in the clinic. And of course, being a radiation oncologist from the perspective of radiation therapy. So I've split it up into 4 categories. So within personalized radiotherapy, what modern technology has done for us, what is adaptive radiotherapy, and how are we going to harness that in the future, where more informative diagnostics, some of which Dr. Rakovich already spoke about, can take us within radiation. And then finally, how do we get to the next paradigm within radiation oncology, which is to use some precision techniques to improve our treatment with radiosensitizers. So I'm just skimming the surface on all these topics, right? Just to give everybody a flavor of what's going on here. So in a 1-slide overview of what radiation is and how it works, essentially it's when you use high energy X-rays and you target it, shoot it at the site of interest, usually the cancer, And what you want to do is get these X-rays to go through areas of DNA within the cancer, cause some breaks to the backbone of the DNA itself. And in doing so, you damage, its ability to spread, to replicate, and cause death in that way within the cancer. So a lot of what radiation oncology has evolved in the last 10 to 20 years has been how to target where you send those X-rays. So just to give you an idea, on the top left over here, this is where things were at in the 90s and early to mid 2000s. So this is a prostate outline in the middle over here of a person's pelvis, a man's pelvis. And you see that in this heat map, there's the full dose of radiation focus here, but there's a lot of radiation going elsewhere as well in the pelvis as well. So over successive generations of equipment and technology, we've evolved to about this point here where we're still delivering a good dose of radiation to where we want it to be at the target, but we've significantly reduced how much radiation is going to the rest of the body, right? And that has allowed us to evolve what we do clinically, that kind of precision with how we deliver radiation. So one example of this, which wasn't possible before, is using a high dose of very focused radiation, and we call that stereotactic radiation, or radiosurgery is sometimes the term used, to completely ablate or kill pockets of tumor that have spread to parts of your body. And especially in patients that have limited metastatic disease, as in only a few sites, 3 sites, maybe 5 sites of spread of cancer, for example, in the lungs, adrenal gland, in the spine, for example. When we do this type of radiation, even though there's in category of stage 4 cancer, we are, first of all, able to extend their time that they're on their chemotherapy or targeted therapy. So give them more, a runway within the drug that they're on. And in certain circumstances, we're actually able to extend that person's survival as well using this targeted ablative therapy. And the theory behind this is some of these early sites of spread, they're actually the bad acting clones within cancer. So that's one of the things that we're starting to evolve towards. It's not like you're diagnosed with cancer, but it's not the same all over your body. So if you can get rid of the areas that are actually spreading and causing the most amount of problem, then hopefully you get better control over this disease. So we've already established that precision radiotherapy has been really helpful in evolving our paradigms with what we can do in treating cancer. So the next level up from that is adaptive radiotherapy, which is essentially where you can use equipment such as this Varian Ethos machine, which is actually going to be installed in the next few months here in Sunnybrook, to look at where the tumor is and where the target is and where all the organs are that can potentially risk side effects on the day of treatment itself and each day of treatment. So for example, if we set up our plans and everything to focus on this area here, but at the day of treatment, it's actually shifted more to the patient's left side, it's kind of reversed. We can adapt for that. So right now, it would be very difficult to adapt for such kind of internal shifts, but that's what adaptive radiotherapy aims to do. And this actually leverages a lot of artificial intelligence for image analysis and also shifting all of the contours and replanning. All of this happens within minutes while the patient's still on the bed. So this is something that is new and evolving and is going to really open up new opportunities on how to use radiotherapy. And to go hand in hand with that is an ability to see better while we're treating. And so that's what this machine is over here. This is actually active in treating patients right now in Sunnybrook. It's called MRI Linac or MR Linac. It's a MRI machine combined with a radiator. And the advantage of that is we can actually see the tumor that we're treating. For example, this is a tumor in a patient's liver. It moves up and down with breathing. This is something that we can actually see as the beam is on. So if there were any unexpected, the patient coughs, for example, and there's big motions, we stop the treatment then. But even beyond that, because we have really modern ways of shaping the radiation beam itself and being super precise in how it's delivering the radiation, we can actually, once again, with a little bit of artificial intelligence, track where these tumors are and move your radiation beam with the tumor. So again, a lot more precision than even what our machines afford today. And that will really pay off in terms of, what we can achieve clinically in the future as well. So treatments that are too hard today will become pretty easy with these kind of equipment. So from there, it's also important to know how to treat and who to treat, right? And so some of this is already, explained before in a much greater detail. But one of the things that really influences is going to influence how we treat patients in the future is what the genetic profile is of the tumor, right? And this is something that I work on in the lab all the time, which is a pathway of determining what genes might actually play an important role and what do I need to consider as a radiation oncologist in delivering radiation for certain patients. And when we find those genes, discover what proteins it's expressing that are important to know. And once you know that, how does it change with, for example, drug therapies, after radiation, the combination of the two? And all of that allows us to predict who will become responders and better responders with radiation and who may not be, and therefore who should get what radiation or what drug or what combination of the two. And to go hand in hand with that, a lot of the work that I've done in the past when I was at the NIH in the US has been on patient-derived xenografts. So essentially tumors that were derived from patients, right? So for example, in this case, this was a patient with a glioblastoma tumor that was taken out, and some of it came to the lab in my hands, and I was able to find markers that predicted for better radiation response with certain drugs. And then concurrently, this is another patient that had this tumor come back after an initial round of chemotherapy and radiation. And again, we were able to find another set of markers to predict how to make it respond once again to radiation, despite it coming back. So these are the kind of things that we are moving towards to really personalize the care. And to enable a much faster turnaround with this kind of diagnostics, and molecular diagnostics is the real term for it, I've also been working on using my knowledge with biophotonics and laser-based microscopy to look at tissues rapidly and give us back the molecular information within minutes, even within patients themselves and live tissue. So before you even take anything out. So the way how that works is we have laser beams focused on an area of tissue. And basically, I'll just summarize this as by the optical properties of the tissue in that area, we're able to then break down and unmix what molecules are actually present, what proteins are actually present, what enzymes are present, what concentrations they're present in. And through that, we're able to generate a map and map out exactly where these molecules and proteins are, just like what Dr. Rakovich showed before. But the goal here is to do this all instead of days and weeks, within seconds to minutes. And so to help somebody like Dr. Law, who's in the operating room operating, to look at a tissue and tell him right away what the molecular profile is of what he's operating on. So he can make a different decision depending on what he finds. And then within radiation therapy, this is something that we're doing and actively researching right now. We've also found that there are some functional differences that we can find with MRI in patients that are responding really well to radiation versus not. So currently, we do radiation, we do a standard course of radiation, and then we have to wait a few weeks and then look at the response just by the size of the tumor. These are in brain tumors in specific. So what we've found is looking at more functional sequences, such as a ADC sequence, which is essentially looking at how cellular that area of tissue is. What we found is halfway through radiation, if they still have a high amount of signal, that means a lot of cells still left behind. That area is not responding well, and that actually predicts for recurrence of tumor in those areas versus immediately adjacent to it, less signal, that part of the cancer is dying faster. So once again, I'm showing you another example of how we think of cancer as this is it, this is your cancer, but it's very heterogeneous, both in the same location as well as throughout the body. And we're really starting to get into the mode of thinking about it as a heterogeneous group and how to treat all parts of it as it needs to be treated rather than as a single entity. So to allow us to even evolve further than that, deliver better treatment, better therapeutic effect, less toxicity, we're starting to look at how to combine radiation with completely new and novel therapies. So one example is what I do with developing nanoparticles that are essentially drugs that don't do anything on their own, but what they do is they home into areas of tumor, collect there, and once they're activated by radiation, they actually take that radiation energy and convert it into really reactive oxygen species that kill the cancer cells from the inside out. So where the radiation itself is, as I said before, trying to break the DNA's backbones, this is essentially attacking every other part of the cell on the inside, as well as the vasculature in the tumor. And in that way, it really synergizes well with radiation. So I'll give you an example of that in what we've done so far, which is in mice. So this graph is basically showing how a tumor grows. So these two lines here is with and without the drug, it grows the same. The blue line is what happens when you give a palliative dose of radiation. So you get a slowdown of the tumor, but eventually it still grows. It just delays the growth. When you combine that with the drug, the same drug that didn't do anything with the red line here, it achieves complete control of the tumor. So much so that these mice live about twice as long. The other thing that has been really important is how to get a faster response to radiation, because radiation can take a while to respond. This is particularly important if you have, for example, a tumor that's compressing the spinal cord, risking paralysis, basically. So what we've also been able to achieve is a much faster degree of response within days. So within 4 days, the tumor shrunk to half its size, twice as fast as the radiation itself was doing. Okay. And all of this was actually really possible because we had an animal model radiation machine that really was akin to what we do clinically. And so we were able to design the plans in the same way, deliver the plans in the same way. And then the other thing that we've able to develop is, just like we do in the clinic, we took a low dose of a CT scan of these mice. So these are 4 different mice in different planes of view. And these nanoparticles are actually visible in the same CT and MRI that we use for radiation. And so the advantage of that is you can see even mouse to mouse, they all got the same dose of nanoparticles, but it distributes very differently in each tumor. And more so, even through treatment, as the tumor is shrinking or the patient's losing weight or vasculature changes, that actually changes. This is something that we don't keep track of right now. But now, with the ability to actually see the nanoparticles, you can actually calculate the dose that you're achieving. And then, so therefore, you may know to use a higher dose, lower dose. So really personalized to the actual patient's tumor themselves, what they need to achieve their cure. So that's how you move away from that scenario where you think you have patients that are all in one category, but some of them are cured and others are not. Well, that's because there are some differences that are happening that we're just not aware of right now. So those are just a few examples that I wanted to present to you. And yeah, I'm happy to take any questions.
Wow. Thank you so much, Dr. Karen Rutt. It was like a tour on some science fiction. That's amazing that it's so close to reality. It's an incredible way to end off, and it brings us a lot of hope for the future. So thank you again to all of our speakers today for what I think was an incredibly exciting and interesting set of presentations, really highlighting the power and the potential of precision oncology in the future. And we are reaching the conclusion of our formal presentation, and now for the fun part, which is to engage our community with questions that they have. We're going to start off in a minute or two. We have quite a few questions, but I'd like to point out to the audience that if there are further questions that you think of even while we're answering questions, please continue to use the portal as it's open for you to continue submitting questions. So one of the first questions I'd like to ask, and I'd actually like each speaker to give a comment on this. Maybe we'll go in the order of the presentation. But I know that this has excited our audience so much that a lot of them would like to know, maybe, or an example, if you can have it, of the impact that this personalized approach has made. From what we've known before to using some of what you've talked about today to illustrate an example where it's really impacted on the cancer's treatment and maybe even their outcomes. So I think some of you gave some examples of that, but maybe you can dig into one a little bit more for our audience appreciation. Maybe I'll start with you, Tracy, if that's okay.
Sure. I mean, just thinking back, when it came to genetic testing historically and genetic counseling as a profession, we really didn't have a lot of overlap or, precision kind of personalized care, because it was all about trying to find a hereditary link to the cancer and then basically dealing with the family members and what testing could happen. And this has been kind of for the last 15, 20 years. It's really only been recently where there's been a real surgence of different genomic markers and different things that we can test for that actually overlap. And I did touch on a few of them. I think the PARPs PARP inhibitors are a really big one right now in our genetics world because it really does potentially have an impact on the overall plan from a medical oncology perspective. A lot of our BRCA carriers, we try to identify their genetic status pretty early on because it really, that information then gets filtered directly to their oncology team, who are going to now put olaparib or volaparib or one of those PARP drugs into the plan for either maintaining, so they might finish their regular chemo and then they might go on a maintenance drug. And there's a lot of data that shows that the overall outcomes and the prognosis for these BRCA related cancers is so much improved by using these PARP drugs. And so I think that's been probably the biggest difference I've noticed.
That's incredible. Thanks, Tracy. Dr. Rakovich, maybe an example from your perspective?
Yes, I think one way to think about it is that because we can now do genomic profiling or molecular profiling of cancers, that has enabled scientists to discover which genes are turned on and drive cancer. That has led to the discovery of targeted therapies, which are often antibodies against the proteins that help stop and slow or reverse cancer growth. So one of the big victory stories in breast cancer, which I treat, is the development of Herceptin. So once the discovery of the HER2 molecule was made and that HER2/neu drives breast cancer, then an antibody to that was developed, Herceptin trastuzumab, which improved the survival of breast cancer. The next, in addition to that, the other discovery or innovation is that you can link these antibodies to drugs so that the drugs are brought directly to the cancer cell by the targeted therapy, antibody drug conjugates. And they too have further improved the cure rate. So this is, and I think one of the questions is not unique to breast cancer. This is happening across all cancers where understanding the molecular profile, this new drug discovery, targeted agents alone or coupled with a drug, testing those in clinical trials, and many of them have already been rolled out into the standard of care. So we are just at the beginning of personalized cancer therapy. There's lots to go, but as we see this developing, then using the standard chemotherapy drugs, which have a lot of side effects, we're going to see reducing that. All this needs to be done very carefully in clinical trials, which is what we're doing, and other centers are doing. That's where the research is. That's where the future is.
Wow, very good, Dr. Karen. How about you? Like that's some pretty fancy radiation treatments you have. Is there an example of something that along your line of work that's made a change already today that people can really hang on to?
Yeah, and I'll just use an example from earlier this week just because it's convenient.
Yeah.
So I saw a patient that unfortunately has a pancreatic cancer, and it's a tumor that's actually just in the pancreas, luckily, but it's not operable. Okay. She had radiation in the 80s for ovarian cancer, and she had whole abdomen radiation. Okay. And so that's a situation where I want to give a high dose of radiation, but there's a lot of risk in doing that in someone that's had a full course of radiation before, right? Because normal tissues in the body, the bowels, et cetera, they can only take so much radiation in a lifetime. So that's a situation that I would have had a really tough time with if we didn't have the MR-Linac over here, because my plan with her is to still do that high dose of stereotactic radiation, try to get rid of this, or at least shrink down this tumor as much as possible, get control over it. But because each day I can see exactly where all the organs are, where the tumor is very specifically, I can do it a lot safer than I would have otherwise. So, this like that, it changed my decision basically in terms of like what I would recommend to this patient.
Amazing. Amazing. The next question I'm going to direct toward Dr. Rakovich. I think what you guys in this first question, you've really given us some really strong examples where a precision or a personalized approach has really started to make big differences, if not already huge differences, in patients' treatment outcome. But I'm sure there's more tumors or cancers that patients face that are probably not as applicable right now. And I think that you touched on something which I think patients would love. Those are the ones I think would be on clinical trials, right? So, Dr. Rakovich, what words would you have for patients, really, the everyday patients coming in who may not understand what a clinical trial is? What would you tell them to reassure them about why it's important for them to be part of clinical trials?
That's an excellent question. We take it for granted. We speak of trials all the time. The clinical trials are the only way that we really can move forward in the discovery of new treatments that are better compared to what we currently do, and to better understand the safety profile. So one can't go from animal models that Dr. Dinakaran showed to treating patients. You have to study carefully to make sure the drugs work, to know what the optimal way of delivering the drugs are and what their toxicity profile is, and that they indeed are better than the standard of care. It is only through clinical trials where individuals can access these new treatments and they can be monitored carefully and closely to ensure that they are better. And then when the trials are done, it informs the new standard of care for everywhere. So it's really important, and that's why we're so dedicated to clinical trials and to expanding the trials to, as best we can and as rapidly we can, get new drugs tested, new radiation techniques, just new surgical techniques tested, and get them into approved standard of care.
That's great. I hope that encourages everyone to know that when they're offered a clinical trial, they're getting great treatment, and we're all learning and trying to improve our outcomes together. That's great. Tracy, I have a question for you. I think, when patients are going through diagnosis and treatment, it can be really overwhelming at times. And sometimes it's only later that they wonder, when should they have been asking for genetic testing and counseling, especially if it hadn't been offered, because so you're so focused on just getting into treatment or what's happening or understanding. Any advice for timing or opportunities to engage a discussion about genetic counseling?
Yeah, that's a great question. I mean, the reality is that there is no perfect situation or scenario for every patient. Everyone is going through this journey at a different pace, at a different rate. And as you said, they might be bombarded or overwhelmed with a lot of other decisions, and they don't want to necessarily add genetics onto their plate at that time. And that's okay. I think that as long as it is on the radar, we can always revisit it. Obviously, there's going to be some patients that would want that information right away up front because it might impact their surgical planning. It might impact, the different types of treatments or drugs they're going to get. And that's great. And we have that facility and that option available to them, and patients can get referred or get genetic testing done, often expedited when we need to make some of those medical decisions. For those that would rather wait, or let's say it didn't come up before and it's coming up later, it's never too late to ask. There's always a good time to ask about genetic counseling and whether they're eligible to be referred, because there are always going to be implications for both that patient, regardless of what point in the journey they're at, but also for future planning. Okay, so for screening for other cancers for them, for maintenance therapy for them, and then of course, again, I always put my genetic counseling hat on and think of the family implications. This isn't just for them. I know that this talk is about your own personalized care, which is wonderful, but it is also the bigger picture for family members.
That's great. Here's a related question. I'm going to follow up with Tracy just briefly, which would be, if I were to come to our cancer center here and realize that I was adopted and I really don't know my family history, how does that affect my ability to get genetic testing today?
Oh, that's a really good question. I mean, that's a hard one. We do abide by provincial criteria, and so we are bound under Ministry of Health funded. And, in a perfect world, we would test everybody as soon as they walked in that door for a full panel of genes if they wanted access to it. And I think eventually we will get there. I think genetics is definitely expanding and becoming more and more widely available, but it's still a big cost. And so we do focus on meeting a threshold. When we know that only 5 to 10% of cancer is hereditary, we want to focus on that really high population that has a high chance of having one of those inherited mutations. That being said, we have recently developed some modifications to the criteria where especially if the person is diagnosed at a younger age, so let's say they are diagnosed with a breast cancer or a colon cancer or some of these cancers under the age of 50, and they're adopted and they don't know any of their family history, we would offer genetic testing to them. And then for those that are older, we do it on a discretion basis. So we're still happy to have a conversation. And some people, based on whatever the situation is, will be eligible, and others may choose an option of private pay. So there is also the option of bypassing the Ontario system and choosing to go through a US commercial-based lab to have a genetic profile done.
Yeah, wow. So I think I hear you. Just ask. It doesn't matter what you know. Just ask. Okay.
Exactly. Absolutely.
That's great. Okay, our next question is also interesting, and Dr. Dinakaran, I'm going to throw this one over to you. This is an interesting one. We'll see what your perspective is. Some of the technology you talked about, it seems amazing. Your MR machine and a few other things. I'm sure this is not at all cancer centers, or we don't think so. So how do you see your role and also community role in terms of how you organize care, especially with emerging technologies like yours? How do patients know that they're getting the right treatment? How does the system work for this thing?
Well, we do work, especially from the radiation oncology perspective, we work a lot with our community centers. So interestingly enough, you might be seeing it, for example, North Shore General, et cetera, like other hospitals, but a lot of the care is still very much coordinated. We have multidisciplinary rounds with other centers, and we actually have really good referral pathways for example, patients that they need some of our equipment, for example. And so, I mean, it's accessible to anybody that really needs it, right? Not all types of radiation needs to be done in Sunnybrook, let's say, but definitely for the ones that benefit, like there's always a path to end up getting to us, or at least, seeing one of the radiation oncologists here to have a discussion about that. So one example is what we do with the gamma knife, for example, for a brain, or spine, where we're one of the centers of excellence for doing that. So a lot of times we get referrals just to have conversations with patients to see if that's suitable for them.
Yeah, that's amazing. I think one thing that all of you have really impressed me in the past is that as you're inventing the future of healthcare, and it can be challenging to get these care to other people, that's another reason you've opened clinical trials, because through the mechanism of clinical trials, you get people access to newer treatments that they may not have had in the standard system, and it can help support them through that. So thank you for all those trials you're doing, and for engaging in our community so they know about it. And I think that for our community out there and for our audience, know that there is a connected network out there. They do know Dr. Dinakaran, and they'll contact him if his treatment is right for you, right? So, Dr. Rakovich, I think moving to you, this is a question that might need your perspective. I mean, you're a cancer leader, you're a cancer researcher, and you're a wonderful cancer doctor. The question is very basic, I guess, is what is the best way for patients in their interaction with oncologists to ensure that or understand if there is a personalized approach for them and if they're getting it?
That's a great question. I think that, first of all, with regards to clinical trials, we are working and continually improving our website. So if you go on the Sunnybrook website, you can find which trials are active and open with the eligibility criteria. So you can, when you see one of us, or even a referring physician from one of our community partners, you can ask, what about this? Does this, would this apply to me? Might I be eligible? So we have revamped that, and we keep that up to date for the general public and our referring physicians to refer to. And, ask. We get constantly emails and phone calls from our community partners inquiring about what trials are open. And so if there is precision radiation or what have you, or certain drug treatments, just ask we work very closely, as Dr. Dinakaran said, with our community partners. In fact, I was at North York General Hospital this morning. We work very closely, and we are a community. And although much of the treatment, the highly specialized treatment, is delivered here, not all of it is, and we work in partnership. So just inquire, speak, and check our website for clinical trials.
Oh, that's incredible. Well, and I'm glad that it's also accessible, so people can look it up. They can learn more and find out more information about this. So I think this is coming to the end of our Q&A session. Thank you to the audience for some of your excellent and incredibly insightful questions. Just a few more points before we wrap up. Please, all of you, please take a moment if you have to fill out the electronic evaluation form that's available on the Speaker Series website, because these sessions are designed for you. They're designed to help us interact with you and make your treatments and your understanding of your challenges easier and better. So your feedback is going to help us plan future talks and refine the way we present them to you to make them more applicable and more meaningful. You can also add your name to our mailing list for our future talks by emailing speaker.series@sunnybrook.ca. Again, Tracy, Eileen, and Deepak, thank you for spending much of your precious time sharing your incredible expertise and for giving all of us hope for the future and also appreciation for the incredible hard work that you do to continuously refine the way we approach this incredible challenge for many of our patients called cancer. Thank you. And a big thanks also to Lori Brady from our senior leadership team at the Sunnybrook Hospital for being here to offer her opening remarks. Again, finally, thank you to all of you in our audience for spending your lunch hour with us at this Speaker Series educational event. We do this for you, and we love it. We love to share our passion. We love to share with you what brings us to work every day. So please, not just our program, but all the programs at Sunnybrook participate in the Speaker Series. So please check the Speaker Series website for all the incredible upcoming talks that you're going to have coming up. And to all of you in the audience today, please have a wonderful day ahead. Have a fantastic weekend just in front of us, and best wishes to all of you. Thank you very much.